An 11-year-old girl is brought to the pediatrician because of difficulty climbing stairs and lifting her arms overhead. Over the past month, she has developed a reddish-purple rash over her upper eyelids and scaly patches on the backs of her fingers. On examination, she has symmetric weakness of the shoulders and hips. Laboratory studies show mildly elevated inflammatory markers and increased serum creatine kinase concentration. A muscle biopsy is performed. Which of the following histopathologic changes is most characteristic of this condition? Choice A, parafascicular inflammation and atrophy. Choice B, endomysial inflammation. Choice C, replacement of muscle with fat and fibrotic tissue. Choice D, tangled and disorganized myofibrils. Choice E, necrosis of muscular fibers. Or choice F, paravascular muscle fiber hypertrophy. I'll wait 5 seconds and answer the question. This should be an easy diagnosis of juvenile dermatomyositis. Dermatomyositis tends to have a bimodal distribution for age, which is to say it has two peaks, one at age 5 to 10 or so, and the other at age 40 to 60 or so. So classically you'll see stuff like in this question with Gottram papules, which are basically these red patches that appear on the extensor joints. So your MCP, your PIP, and your DIP. And you also have the heliotrope rash, which is a rash around the eyelids. I didn't put it in this question, but it's also associated with ANA, anti-Jo, anti-MI2. ANA is sensitive but not specific, while anti-Jo and anti-MI2 are specific but not sensitive. Which is to say, if I don't detect ANA, then I can pretty safely rule out dermatomyositis. Not 100%, mind you, don't make that mistake. And with anti-Jo and anti-MI2, since they're specific, that means if I detect them, I'm pretty confident with ruling in dermatomyositis. But because they're not sensitive, if they're absent, I can't rule out dermatomyositis. In lab studies, you can also see elevated CK, LDH. So in this condition, obviously you have a muscular weakness, and that's because you have autoantibodies attacking the muscular fibers, which leads to parafascicular inflammation and eventually atrophy. So choice A is the correct answer. And yeah, they've actually tested very specifically on this. I would say you want to be careful and be able to differentiate it from polymyositis, which actually does have a different pathology behind it. You usually hear people talk about dermatomyositis and polymyositis together, but they actually have slightly different pathological causes. So whereas dermatomyositis is mostly antibody driven, polymyositis is mostly T cell driven. And instead of attacking the perifascicular area, it attacks the endomysial area, which is what we have as choice B here. And the easy way to remember this is just that obviously dermatomyositis has cutaneous manifestations and polymyositis does not. And the endomysium is way deeper than the perifascicular layer. So let's take a look at some of the other answer choices here. Choice C, replacement of muscle with fat and fibrotic tissue. This is describing Duchenne's and Becker's. Obviously also a pretty high yield condition, and there's a lot we could talk about, right? It's X-linked recessive. Duchenne is a frame shift mutation, whereas Becker's is not, and that's why Duchenne's is way more severe than Becker's. And it causes a problem in the dystrophin gene, which provides stability for the cytoskeleton, and it anchors the myofibers to the cell membrane. You actually have to know that. And this lack of dystrophin leads to a cycle of muscular degeneration and regeneration. So you end up with muscle that's been replaced with fat and fibrotic tissue. And that's what leads to the very buzzy findings in Duchenne's, which is where you have calf pseudo-hypertrophy. It's not hypertrophy, it's pseudo-hypertrophy, right? Because it's not actual muscle tissue. You have what they call the Gower sign, where the patient has to kind of crawl their way up their legs. And unfortunately, patients with Duchenne's usually only live for around 30 years. Becker's presents a little later, usually in their teen years, and they can live a bit longer as well. Choice D, tangled and disorganized myofibrils. This is mostly describing hypertrophic cardiomyopathy, HCM, which can become HOCM. Sometimes you'll hear people talk about HCM and HOCM interchangeably, but they're not technically the same thing. HOCM is more like a specific subtype of HCM where, as the name implies, the hypertrophic cardiomyopathy has caused an obstruction. So anyway, in HOCM you have concentric hypertrophy of the cardiac muscle. and it ends up with this disorganized growth of muscle tissue, essentially. Choice E, necrosis of muscular fibers, is mostly a distractor. I mean, you can argue it's some kind of damage from ischemia, trauma, toxins. It could even be the damage from something like Duchenne's acutely, if you biopsied while the muscle was damaged and it hasn't healed over with the fibrotic scar yet. Like I said, it's mostly a distractor. Choice F, perivascular muscle fiber hypertrophy. This is a complete nonsense distractor that means nothing. I put it here because it's also on the NBME, just in case you needed proof that the USMLE actually does throw in complete nonsense answer choices just to trick you. So, bring it back. Dermatomyositis, bimodal age distribution, Gottram papules and heliotrope rash. ANA is sensitive but not specific. Anti-Jo and anti-MI2 are specific but not sensitive. Lab studies might show elevated creatine kinase or LDH, and it will lead to antibodies, which will damage muscle and lead to perivascular inflammation and atrophy, not to be confused with polymyositis, which can lead to endomysial inflammation. I hope you found this video helpful. I'll see you in the next one.